So I'm Dr. Shadi Rafid. I'm a boarded small animal surgeon and the owner of Vet Triage. You should have at your seats there's a pamphlet for PRN. They're sponsoring this, so you can take that with you. Then there's this fleshy prosthetic. You can open this up if you'd like. Well, actually, go ahead and open it up. Might as well. And then there's instruments at your table too, needle holders and thumb forceps. You can also open. And then I have each desk. There's a 2.0 and 3.0 suture. So if you run out of suture, I have plenty over here. And in fact, I also have 4.0 if somebody finds you to use 4.0. Let me know, I'll bring it over to you, or you can come grab it, whatever you want. And then I do have these suture scissors, in case you hate the scissors that are attached to needle holders. Let me know, or just come up and grab some of these as well. And then at the end of this, before you guys leave, I do have prosthetics you can take home with you, mini ones, so you can practice at home. It's got the PRN info, of course, on there, but yeah, mini versions of what you have there in the envelope, so you can practice at home as well. So, all that stuff there. Hi guys, come on in. Welcome, welcome. Perfect. Great. All right, yes, feel free guys who just walked in, open up your packet there. You should have a prosthetic in here, needle holder, thumb forceps, suture, and then before you leave, just make sure you let me know, and I'll just give you guys this to take home with you as well, a little mini fleshy prosthetic to practice at home. I also will remind you too, a couple things. Number one, this is an open forum. Talk, ask questions, help each other out. There are suture patterns in here that I don't really use, but I know people want to learn about them, so we have them. And some of you have probably done those patterns. So feel free to help each other out. It's very collaborative. And then also, there's a range of people who come to these. Some folks are really advanced, and this might seem very basic for you, and others have never even touched surgical equipment before. Yeah, so even like holding them and things like that might be a challenge. So this is meant to kind of be for a broad population of folks. So if you find it kind of slow and simple, just wait. Maybe you'll unlearn bad habits or learn new material. And if it's brand new to you, great. Don't feel shy. Ask for help. We're all here to help. And of course, I'm happy to walk around and make sure you guys are good. But any questions that you have, let me know. It's always a fun conversation to have with these because there's so many different ways of doing this stuff. Okay. So my background, I graduated from Cornell University in 2006. I then went to Boston for my one-year internship in 2007. I then completed my surgical training at Long Island Veterinary Specialists in New York, followed by a specialty center position in Las Vegas. I then managed 3 hospitals on call 24/7 for the 3 locations in Silicon Valley for a year. After that, I became part owner of a hospital in Los Angeles, was chief medical officer there for surgery, internal medicine, and oncology. And after a year and a half of that, I started Vet Triage, which is a telehealth platform, the first one ever created. And feel free to ask me any questions during or afterwards regarding telehealth if you have any inquiries about that. This is our outline. We're going to go through a bunch of stuff. Right around here, we'll take maybe a 10-minute break, give everybody kind of a breather, and then follow up with what I call bonus material, things that are maybe a bit out of what you're planning on doing, or maybe it's right in line with what you want to learn, but these are some other more advanced techniques, let's say, that we'll go through as well. Thank you to PRN. If you haven't visited their booth, please visit it. They're fantastic. They're sponsoring this, so thank you to them. And then Dr. Miller was one of the OGs that instructed this course, and so all these slides are his. I modified them to fit my own style. All the videos are his, so I thank Dr. Miller as well for contributing those slides. Okay, so before we go into practicing, we're going to go over some basic surgical techniques or etiquette. This is how you typically will hold needle drivers. Now, there's another way of doing it as well, where there's a palm, that you can palm it as well. Large animal surgeons will use that a lot, but typically most of us are holding it in this manner. And I do apologize, I realized yesterday we had like 2 or 3 left-handed people in the class. So do your best. I only have right-handed equipment. Ring finger in one loop, thumb in the other loop. These 2 fingers are stabilizing the instrument. The goal here is to allow you to have control over the instrument without creating unnecessary tension or stress in your hands and your fingers. You don't want the surgeon to be fatigued, right? Surgery is stressful enough. It's long, it can be quite laborious. Last thing you want to do is create stress where it's not needed. These instruments are not meant to be powered through, it's meant to be finesse. So you want to make sure that your grip is secure, but also light. And the same thing goes with thumb forceps. Hold it like a pencil or a pen, and it should be controlled, but also a nice loose grip so you feel relaxed. That's the idea here. You can build up a lot of tension. If your surgery is going to take 2-3 hours, that's a lot of tension that you can avoid by holding things appropriately. So just some key items there. Before I go forward, how many folks here are veterinarians? Okay, and how many technicians? Yeah, anybody I'm missing? Those are the two. Yeah, good. Another reminder, posture. So, this guy's really tall. He's kind of bending his neck, bending his back to make do. This is unnecessary. This type of posture is, again, going to create neck and back problems. Many of you are going to be in the profession for decades. Some of you might retire in this career. So you want to make sure you're saving your body. And so if you're really tall, then either raise the OR table, or if you already have it at maximum height, then spread your legs so that way you sink down. And that's a nice way of keeping minimal tension on your shoulders and back and your neck, and you can operate, versus being really tall and doing this. We tend to do this because we want to look at the procedure and be in it, but that's not good for your long-term back and spine. Spread the legs, come down, or if you're short and you already lowered the table as much as you can, get one of those stools and stand up on that and get yourself hiked up. Whatever you have to do to minimize this type of tension. You won't notice it in surgery because you're so focused on the operation, but you're holding all this tension in from bad posture, and there's no need for that. So try to create the optimal environment for you as a surgeon. And if it's your operating room, well then you can set it up how you need to set it up to fit your body. But don't try and force it. Make it where it's going to be as physiologic for you as possible. Any questions just about that kind of stuff? All right. So let's get into some details. Suture type. So you can divide suture types into various categories. One is the duration. How long is it going to last? Typically, you want the suture to last days if you're talking about mucosa, subcutaneous tissue, and skin. Fascia, weeks, tendon, months. The degradation profile is another way of categorizing suture. So they are either going to dissolve really quickly or really slowly or not at all. The structure of the suture determines typically the degradation profile of it. We'll go more into the next slide. And in general, monofilament and multifilament or braided suture are the two options that we have. Most of us are using monofilament. I have never used multifilament, but it's certainly a popular one, especially amongst old school vets, but vets do find a use for it. It does have excellent handling, excellent knot security, but the problem with it is that it tends to harbor bacteria and debris, and that's the downfall to that structure type, whereas monofilament, super smooth, so less tissue drag. That's the suture we'll be using is monofilament. You're going to be able to feel how smooth it is right away. Less likely to harbor bacteria because it's monofilament, it's one structure, and less likely to cut through friable tissues. It's not as, let's say, aggressive in its structure as multifilament. So when you look at the structure of them, this is why multifilament tends to harbor bacteria and debris, but it's also why it has excellent handling and knot strength because of this pattern. Monofilament is by far most commonly used. So suture type is defined by type of suture and duration of healing, absorbable versus non-absorbable when it comes to degradation profiles. So obviously absorbable is going to go away, non-absorbable is going to be permanent, and then the structure of the suture type. With suture size, you want to use the smallest suture size possible that gets the job done, right? Because keep in mind, when you're penetrating the tissue, whether it's skin or stomach or whatever, with the needle, you are creating trauma. So the smaller the needle, the better. However, you also want to make sure that when you place the suture, that you're minimizing the amount of foreign material in the body. That suture material, even though it might be absorbable, is foreign body. It's going to create a reaction. But you also don't want to use such a small needle and a small suture size that you're not getting the job done. If you're trying to close this massive wound on a Rottweiler and you're going in there with 4.0 PDS, not only will it take forever, it's going to require multiple layers, and it's probably going to fail. That dog is going to stress your suture. So you have to weigh the pros and cons of having a large size suture needle and suture material, but also realizing you do create trauma and you are placing more foreign material. So you want the small size that makes sense for that situation. That comes over time and experience and trial and error, but just keep that in mind too when you're operating. So we're absorbable suture. We have short-term used in mucosal structures of the facial and oral region. Dermal, especially in young animals, you get 6 to 7 days of wound support with complete absorption in about 2 months. And here's an example, Monomed ST. Midterm, that you'll use for general closure, skin repair, subcuticular, various organs, 14 days of wound support. It goes away in 3 months. Examples, Monomed MT, which I think is what we're using, I believe. and then long-term general closure, subcuticular, cardiovascular, and organs, wound support for 35 days, absorption in about 6 months. So it all depends on what you're trying to achieve with that suture pattern. Okay, this will be our first suture that we're going to practice. If any of this stuff seems rudimentary, again, just bear with me. It's a nice reminder. I'm going to start with describing it, which for most people probably is kind of useless and confusing, but then we'll have a drawing and then a video describing it, and then we'll practice it. Square knot is the most frequently used knot when placing ligatures and sutures. It is the most secure knot and least likely to unravel, but not great in areas of tension. The square knot consists of 2 simple throws, with the second simple throw in the reverse direction of the first. Both throws must begin with the needle driver between both strands of suture. Think of both sides of the suture as a circle. You're going to stay in the circle. We'll show you that in the video. If it helps, watch just the short end of the suture. It has to go side to side. Start on one side, go to the other, back and forth. This is what you're looking for. I call it a pretzel shape. You're looking for this shape when you know you're about to create a successful square knot. That's what you're aiming for. This picture are 2 square knots on top of each other, because typically when you're closing a wound, you're going to have multiple throws. So you're going to probably have 3, 4, 5, 6 of these on top of each other, depending on what you're trying to do. But that's our goal with the square knot. So here's our first video. This is Dr. Miller performing the square knot. So we'll go through it, and you're welcome to start practicing as you watch it. He's taking a bite on one end, crossing the wound bed, exiting the other side. You're keeping the distance between where you enter and where you exit about the same. And then this is the circle part, where you stay in the circle. He's showing you I'm creating that circle, and I'm going to stay in it. Create that circle, grab the free end, and pull it through. There's that pretzel shape, and then tie it down. Repeat the process on the other side, and continue going back and forth. I'm going to replay the video multiple times for those who still need to look at it a few more times. But this is what you're trying to achieve with a square knot. Now, how many throws depends on the surgeon, their preference, their experience, and what you're trying to achieve. You know, if you can imagine, you're placing a square knot underneath the dermis of, let's say, like a cat or a ferret that have very thin, I'm going to restart the video, that have very thin outer layer. You don't want a big, bulky knot. It's going to create irritation and erosion. But if you're working in the laryngeal area of like a fat old Labrador, you want lots of knots there, and you have plenty of tissue to cover up that knot. So that's how you kind of choose how many throws you want. But typically 3 to 5 are what you're looking for. So again, there's the loop. And he's going to create that loop, grab the free end, come across, and then create another loop on the other side, come across. So I'll keep replaying the video. I'll walk around, see how you guys are doing. And like I said, some of you might find this very basic, and others might be your first time. It's all good either way. A couple things you'll notice too with the prosthetics is, like, obviously it's not real skin, so there's some drag to it. There's also no like blood or bodily fluids, which doesn't help with the smoothness of the suture. This suture is very, very smooth, the monofilament. So even when you tie your knot, you might be like, it's not really tying. That's because of the nature of what we're working with here. In real life, it would tie just fine. With the prosthetics being what they are, you just want to get the shape down for what a square knot looks like, and then take it from there. You'll notice if you put unequal tension for the square knot, it's going to create what's called a slip knot. And the slip knot is a real knot, but it's not what we're really going for here. You want to get a nice square knot. So equal tension on both sides when you're doing this. Yeah, the needle holders they're brand new, so they're a bit tight. There you go. Yep. Always staying in the circle and go up the way. stay inside. It's all right. There you go. Equal tension, that's how you get touched. Yep, that's good. Good. Play it again. There you go. That's actually really going on. There you go. There it is. Yep, there it is. And then just keep equal tension, that way you don't have that. There you go. Yeah. It won't look as weird in real life. It won't look a lot of fluids because it's kind of jumbled up. But yeah. The importance with this is that this is the foundation for all the suturing that we're going to do. So I'm going to make sure you guys are comfortable with this part of it. Another minute and then we'll move on. How many folks here are large animal or work in large animal practices? Yep, there you go. Yeah. And how many? The rest of you small animal? Presume, yeah. How many exotics or pocket pets? Nobody? Nice. Oh, okay, okay. Very cool. Good. Cool. There you go, that's the direction. There you go. Inside. Yep. Circle. Okay. Yep. Good. Yeah. Good. So this next slide here, I drew this. This is why it looks ghetto, but this is showing a point that Dr. Miller doesn't show in the videos, but I'll talk you through it. So you notice in the videos when he's penetrating the skin on one side, he's going across the wound bed and he's going and exiting right out the other side, right, just straight through. What I'd like you to get in the habit of doing is instead of going straight through, you take a bite on the one side like you normally would, but instead of going straight through to number 4, you exit, so following number 2, then take your needle again, reinsert into the opposite side, and then come through. You're achieving the same goal, but you're not taking one bite straight through. The reason for this is I think this is better surgical technique because then you're not forcing a curved needle to go through in like a linear fashion, so you minimize bending or breaking that needle. And if you're working with a really big dog that has a wide closure, a wide wound, this is going to be very annoying. You're going to be forcing it through. Remember, these are delicate instruments and suture material is delicate. So I would get in the habit of exiting out the one side, re-entering the opposite side, exit fully, and then re-enter. So just keep that in the back of your mind. I'll point out in the next closure as well, but I think it's important for surgical technique, surgical etiquette to minimize frustration and work on your part. It does take a little more time though, of course. What Dr. Miller is doing when he goes straight through, he's saving time. And of course you can do that, because if you're working with a really tiny incision, why not? But I want you to get in the habit, especially for the folks who are newer at this, to do it that way. The next knot we're going to learn is surgeon's knot, also known as the friction knot. The surgeon's knot is often used in high tension tissues that cannot be properly opposed using a square knot. The surgeon's knot differs from the square knot due to an extra pass through the loop of the first row. So a double overhand knot followed by a single overhand knot. This extra twist in the first throw provides more friction to maintain its position until the second throw is placed. Those are the words, that's the picture. So this here, I call a double pretzel. So you're doing what you just did, the square knot, but you're adding another loop to it before you tie the knot. This is the surgeon's. This is a square knot that you just did. So typically what you're going to do, if you're going to use a square knot, it's your first knot, and then it's supported by subsequent square knots, which is what you just did. So I'll show you a video here of the square knot. Also, if folks care, I do have a YouTube channel that I'll share at the end. I post these videos on my YouTube channel too, so feel free if you need to, you want to relearn these things at home with the prosthetics we're going to send you home with, you can also watch those videos too on my channel if you wanted to. I'll share with you at the end. So the same bite as usual, right? Going from one end to the other, but now instead of making that one loop, you're going twice. Boom and boom. See that? So it's just like what you just did with the square knot, but now you're doing it twice. That's the surgeon's throw. Then he's going to follow it up with a square knot, so creating one loop. And then subsequent knots are going to be all square. Square, 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 square. But that first one is the difference here, where you're going to be performing a surgeon's knot instead of a square knot. I'll repeat the video a few times. Now, I almost exclusively use a surgeon's throw. I'm not really using the square knot that often. There are some times where I'll use it, but otherwise I'm pretty much using a square knot as the surgeon's knot as my first knot. But that's up to personal preference and experience, what you're trying to achieve. So again, it takes a bite from one end to the other, and then a double loop to create that double pretzel shape. And hopefully, again, it might be hard on the prosthetics, hopefully you can feel the added security when you're doing the surgeon's knot. It may not be so obvious here because of the way this is, but in real life, you'll be able to feel how strong this knot is. Usually one surgeon's throw, and then maybe 2, 3, 4 square knots after that. Kind of depends on what you're trying to achieve, what your experience is. So we start again. Let's see how you guys are doing. Yeah. No, go for it. It's all right.
Okay, so how do you get this? How do you get out of this?
Yeah, so the question is when you first penetrate the skin with the needle, now you have like the needle and the suture in your hand, like how do you manage that? Literally in my hand. I'm just holding it. Yep, I'm wrapping it around my hand. If you see somebody who's really been used for a very long time, they can actually wrap it around their hand like officially. It's like a spool. I have never gotten there. I've been for 20 years. Yeah, so you just hold it in your hand like that. That's what you're trying to do when you have that suture in your hand, is you're trying to avoid it from leaving the sterile field. That's really what you care about. So if you start noticing that your free end of the suture is hanging on the table, now technically speaking, no good. You need to throw that suture away and get a new piece of suture. You also want to make sure that when the suture material is flinging around, it doesn't touch like your nose or your chin or your hair or whatever. Again, that breaks the sterile field, and so you have to start over again. Otherwise, it doesn't really matter to me how you do it. Yeah. Stay in the circle. There you go. That's one that I was in this class. I never did it clinically, but I love it. Yeah. Yeah, yeah. It's usually a tension issue with that. Try to keep people's tension. Yeah. I've noticed that a lot too, but a lot of people turn into a slip knot or a granny knot. And it's just subtle. Like but we do this hundreds of thousands of times and eventually you look like you're looking at it, you know. Play it one more time and then your folks are ready.
Pretty much.
Yes, he's not too tight or that was a difference. So, it looks like probably more throws anyway on these. Oh, okay.
I was like, those surgeons saying.
Feel good? Feel more natural? Look good. sometimes the
Yeah,
prosthetic
like
rips.
in and out. Yeah.
Nice. You guys doing okay? Oh, nice. Okay.
Well, I moved to Tennessee a year ago.
Yeah.
So this is
Brand new. Good. Yes. Probably so. Yeah. I mean, it's whatever you're comfortable with, of course, but. They try and take bigger bites when you're going through, because the process, well, in real life too, you can tear the skin, of course, and you have suture pull through, but with the prosthetics, they know you could tear it. So if you tear it, just take a bigger bite. Good. All right, simple interrupted. So a lot of you folks have already done this unknowingly or knowingly, but the simple interrupted is the first pattern we're going to talk about. What you did just now are knots. These are going to be patterns. So this maintains tissue position and strength if one portion fails, has minimal holding power against stress. It requires more time. It does require more suture. This is definitely the go-to for people who are just starting with surgery. It's simple interrupted. And so this is what you're ending with. And again, you probably already have this in your prosthetics. You've already done this, but we'll show a video anyway. How far apart you have it depends on what you're trying to do. If you're working with like small intestine, for example, you're going to want to be pretty close together. And if you're working with maybe doing like a long incision, like a radical mastectomy, then you may have them farther apart. You want to try and make them fairly equal throughout. And if you feel as though that the space between your two sutures are too far away, you can always add another suture in between. Over time and experience, you'll kind of learn what the adequate distance should be. But obviously, if you're dealing with high risk, like a gastrotomy or an enterotomy, you don't want any leakage, and so you want to make sure you know the spacing beforehand. So Doc started with a surgeon's throw and then square knots, and he's going to finish that off the same way we've already done now a few times. Cut the free end, and then continue on with the simple interrupted pattern by repeating the process, and you just go down the line with interrupted. And it can be square knot all the way, or it can be surgeon's knot first and then square knot subsequently, but this is the simple interrupted pattern. You just continue this along. So that already will take care of most of your closures. What you've learned so far is going to be sufficient for the majority. Any question on this one? Otherwise, I'll move on. You've already all done it. Let me make sure. All right, cruciate pattern. Here we go. So, two simple interrupted sutures placed parallel to each other, tied across the incision. It forms an X. That's where the name cruciate comes from. It's an appositional pattern, good for low and moderate tension. We're going to talk about appositional now. Security is similar to simple interrupted, but it's faster. I love cruciates myself because it is faster. And Dr. Miller uses it for cat body wall. I use it for incisions that are very long and very annoying. So again, the radical mastectomy is a good one. It's always a long incision down the entire body. It takes forever. So cruciates are my go-to. Let's talk about appositional. There's three different types of wound closures in general. Appositional means head-to-head. So one end of the incision is going to touch the other one, head-on, nice and flat. That's what you've been doing. That's appositional. Inversion, or an inverting closure, is when the two sheaths, instead of going head-on, they're going to suck in. So for example, uterus, stomach, urinary bladder, you're going to have the closure where it sucks in. That's on purpose. You want that inversion. It creates a tighter seal, and it also eliminates any suture exposure to the outside, where you can form adhesions in the abdominal cavity that can cause problems for the patient. That's inversion. Then eversion is the opposite. Eversion puckers up. Typically, you're not purposely creating eversion closure, but sometimes you want to. But most cases, that's more just bad technique and not on purpose. But eversion is it puckers up and goes that way. So appositional, head-to-head, inversion, and then eversion. That's what they mean when they talk about appositional. This is the cruciate. This is what you're aiming for. So now, instead of taking your bite and then close and then creating your knot, instead of doing that, you're going to re-enter the first side that you initially started with, and then go through again before tying the knot. And when you tie it, you get the X pattern. So here's a video. This is a great suture pattern for speed. It does use up a lot more suture material. and also is a very strong closure. So for high tension areas, I love the cruciate pattern, it's fantastic. So Dr. Miller is taking a bite from one end to the other, as you've done already, but now instead of tying off the knot like you would have if you're doing simple interrupted or any other kind of interrupted closure, he's going to start again. You're starting in the same plane that you began with, going across the entire incision. So notice you have the free tag here, the free end, taking a bite, going across, and again, ideally you would exit and then re-enter. Better technique, I think. Come through, so you see how you have a loop now in the middle? Tie it all the way through, or pull it all the way through, and then surgeon's throw, and then grab the free end and tie across, and you're forming that X. I'll replay the video again. You don't have to do a surgeon's throw, but I recommend it because chances are if you're using a cruciate pattern, it's probably because it's a high tension area, and so you're going to want the added security of a surgeon's throw, and then follow that up with square knots.
How much tension do you put to make the apposition, kind of take into consideration closer swelling and
Yes.
tissue? Because I know that varies a fair bit between species.
Yeah.
So do you kind of leave it a little bit loose there
Yes. So
in most models?
So when I was going through vet school and in my early surgical training, I would get told things like, oh, you want to leave room for their postoperative swelling. So if you do it too tight, then the incision's going to swell up, and now you're going to have this constricting effect. And then I heard the other thing where it's like, oh, if it's not swollen right now, you can go down pretty snug and you're okay. And so this sounds kind of opposite. So basically, my general rule is, if there's no swelling currently, I'm going to go down to a comfortable level, so when I feel like the apposition is pretty good, and that's pretty close to the skin, like that's pretty snug. If there's already like inflamed tissue, it's all swollen and it's full of edema, then I'm going to go pretty loose on it, and not just so that edges touch, but I'm not pushing down on it. The idea with any of these closures, folks, is you're trying to avoid not crushing the tissues, right? So not only do you want to leave room for inflammation, like Doc is saying, but you also want to not crush the tissue. That doesn't help anybody either. However, if you're working like with small intestine again, where the risk of spillage is very, very dangerous, you want to be tight enough that you're creating that seal, but not so tight that you're killing tissues either. So that takes finesse and time to do that. But yeah, with the cruciate pattern, I go pretty snug right at the moment of surgery, unless the tissues are already kind of angry, then I'll ease up on it. If you're noticing when you put a couple of cruciates in, and now this underlying skin is starting to blow up, it's getting red and swollen, puffy, maybe you already know you put it too tight, and you might have to redo them. Or the animal has like a coagulopathy, or there's something wrong with them. You know, there's that possibility too. But if you're doing a radical mastectomy, for example, long incision, you'll know by 4 or 5 in whether or not you're going too tight, because the skin will get inflamed and swollen. That was good so far. There you go. And then also finish on this side too when you're pointing through. Finish on both sides. Yeah. And then through. Yep. Yep. Tuck that away. There you go. And then you want to do surface knot. That was a square knot. There you go. Yeah, there it is. Boom. And then square knots. And you should feel the strength of this one, right? Even on prosthetics, you can appreciate how strong the cruciate is. It really like brings the tissues together. It's lifted up. Yeah. That's the problem with the home prosthetics too. It pulls up really easy. It's annoying. Yeah, that's when you know you've got some good tension on it.
Do they always come this way?
Yes.
You know, hiding.
I'll say, I need some lunch and like, you know, they're holding.
That's right, they're holding. Oh no.
Yeah, this was swells.
Force it up on there.
Right.
I think it just loosened because of the way the suture is, that's all.
Okay.
Anything else, that's
Yeah.
good.
So did I just do 4 knots? 2 full knots because there's 1 on each side.
Yep.
So I would go this way to the surgeon's, and then this is the,
Same direction, just doing one loop instead of two.
so this is the surgeon's.
Yep.
And then if I'm coming from the other side.
If you do a square knot,
Yeah.
same thing, we just do it once.
Right, but if I had already tied it and then I was doing, like pretend this is over here.
Yes.
Then do I come back this way?
Yes.
Okay, so it goes away from me and then it goes toward me.
Well, it depends on how much direction you ended with, so if you timed this,
You're
right?
watching me.
Yeah. No,
Yeah.
yeah. Yeah, done so many times.
And let's just pretend just with the time. So then I would
Two, that's the surgeons, yeah.
pull through, so that's right.
The other way, so it would be this way. Yep, so unravel it. You also probably want to take bigger bites to finish it through.
Like how far out?
Couple millimeters, it depends on what you're trying to achieve. What's the bottom?
Okay, so. So like all the way up.
Yeah, yep, it's okay. Loving that technique.
Okay, so now.
Do slow.
I'm doing this.
Yep, 2 loops.
2 loops.
Grab it free.
And I grab it. And I pull straight this way.
There you go, that's it, see?
You
now,
pull it back the way you can.
Yeah, yep, see, look, now you have that pretzel shape. See that? That's the pretzel shape.
Yeah.
So, and then after the next loop, come on this side.
Okay,
Yep,
so now
yep.
I go this way.
Yep.
And then grab
Grab that.
here.
Mhm.
And then pull it. Flat this way first.
Yep. You want to see that loop, you want to see that pretzel shape. Yeah, that way you know you're really flat.
Yeah, that's good.
There you go.
And now I pull tight.
Yep, and then pull tight.
So my tail ends on this side of your side.
No, it should alternate.
It's not.
Yeah, so if it did, then we went the wrong way.
Got it, okay.
Yeah, we get used to that. That's the key to all this stuff is learning that part. Yeah.
I mean, I don't know, every day is 1,000.
And we do another suture, so a full one, yeah.
Thank you.
Take bigger bites and make
Okay.
your loops really wide, that way you can actually see
Okay.
the pretzel shape.
That's a good idea. I think all of us are probably wrong. Thank you.
Okay, horizontal mattress. So the horizontal mattress pattern starts by creating a simple interrupted pattern, but instead of tying the suture, the needle is inserted 6 to 8 millimeters laterally. Don't worry about the number, we'll see it in the video. On the same side as the needle exited, it crosses to the other side of the incision to exit directly across the same number of millimeters lateral to the first site of entry in the skin. The suture ends, which should now be both on the same side, are then knotted. Good for tension, could cause some eversion if not applied correctly, could cause some vascular issues, but you can prevent this also with buttons or tubing. Let me show you the drawing. So, you're entering one side, exiting, now you're staying on the same side, re-entering, going the opposite way. Okay, so the cruciate, we went across, right? And then took a bite. In this one, we're gonna stay on the same side. So here's the video. This one I use a lot for imbricating tissue, so stifle surgery, for example, patella luxation or cruciate tear. I'll use it for that, it's very strong. So take a bite like normal, go across, but now, turn the needle around, take a bite, staying at the same level where you exited, same level where you exited, come through, the other side, you're gonna exit at the same level that you entered, see that? Creating a loop on this side, kind of like a horseshoe. And then surgeon's throw, and now notice that when he ties the knot, it'll be parallel to the incision, right? That's the horizontal mattress, because the next one's gonna be vertical mattress, so it'll be the opposite direction. Horizontal mattress, tie it parallel to the incision versus surgeon's throw, because again, this is an area of high tension, and then square knots thereafter. And you should also feel, I'm going to replay the video several times, this part here is going to kind of pucker inwards. It's going to indent, it's going to dimple in there. That you'll feel that strength. That's the point of it, is to bring that tissue closer. It's a very strong suture pattern. You should be able to feel that dimpling effect on that opposite side. You can see why there's the risk of disrupting the blood vessels, because when you finally tie the knot, it's literally going across the blood vessels that are entering that skin. But if you use this the right way, it's not really that much of a concern. And also using this usually on tissues that are a bit tougher, so like fascia, for example, or like joint capsule, and those vascular areas, they're not very vascular, so the risk there is pretty much minimal. I haven't had a problem yet with it, but it's very strong. I also use these for skin that keeps on failing, like if you have a large obese old dog and you're removing some sternal mass and it keeps opening up, I'll use this if I have to, risking blood vessel disruption, but it's such a strong pattern. And hopefully you're feeling that tucked in thing, that the power of the tension. Nice. Another way. There you go. Yep. Surface throw. And go parallel to the incision. Nice and slow, so you can notice the double pretzel shape. Now a little bit. They should feel it. Feel this part, see how it's like indenting? That's how you know you did it right. It's pulling it through. And it's supported with square knots. This is between this first one and the second one?
Yes.
Yeah, so the same rules are going to apply. So the distance between these closures is the same as your other closures. You kind of, through experience, you want it to be close enough together that if you want a really like airtight seal, then you get them fairly close, maybe 2 millimeters, let's say, apart. If you're closing a larger span of tissue, you don't really need that airtight seal, then it can be longer, maybe 3-4 millimeters apart. It just depends on what you're trying to go for. With this pattern in particular, I use this pattern because of the risk of the microvascular disruption. I use it for problematic areas. So usually if I'm using this, I'm using it for like 2 or 3 in a row, and then that's it, and the rest of the incision will be like probably simple interrupted or cruciate or whatever. I'm not using it for like an entire long incision.
Is there like a bite, like if I were like, okay, so to go for like, bring it all the way over here.
The width of it, yeah. So yeah. Yeah. No, it'll probably match like this distance.
Okay, so like this is pretty small, like it is like if you took a bigger bite.
Yeah, I probably would err on this.
That part,
Yeah,
stay
yep.
there.
Yeah, you're mimicking the distance that you had.
Okay.
Yeah. If you make, so she's asking about that U part of the shoehorn, like the horseshoe rather. So if you make this really wide, if this is a really long one, you're now incorporating more blood vessels into the closure, and so risking that blood supply issue we talked about. So you want to stay pretty close. So as you can see here, he pretty much kept the same distance. Move your hand, Doc. The same distance from the incision to the suture is pretty much the same length as that U part of the horseshoe, roughly speaking. But yeah, you don't want to go too wide, otherwise you're going to incorporate more blood vessels into it. Yes?
much tension do you want to put at the end, I guess? Because if you're doing it, it's a high tension area anyway, so you don't want to pull and crank it down just to small it enough.
So the question is how much tension when you do this? It's going to be a fair amount. If you want to at least get that feeling that the tissue is dimpling in, that it's being sucked in, you want to at least get that. Yeah, that's kind of the point of it, is to close that dead space and bring that layer closer together. Yeah. Same idea as the previous question with cruciates. You don't want to crush the tissue.
Okay.
Yeah, but you're looking for that dimple in, that sucking in effect. Yes. Yeah. Good. So stay on the other side. Yep, exactly. Yep, two. Now nice and slow. Good, that pretzel shape. There. See that? That's what you're looking for. That pretzel shape. You want to do it again? It's looking all mangled because of the unequal tension. If you're pulling on one side more, you'll keep on doing that weird twisty thing. Yeah, just keep trying it. This is going to be repeated things, the whole process. So either you have like an insert, do it right, or you just position yourself so that you don't risk breaking sterilization. Just have it lay on the table. There you go. If you're ready, we'll do the vertical mattress. Everybody okay? Oh yeah, do you want this? Yeah. Is it 2-0, 3-0? Yesterday I had mixed opinions on the size of suture. 2-0 or 3-0? Matter? Someone else needs it? Yeah, 2-0. You want 2-0? Yeah, I can do 2-0 that way. So vertical mattress involves entering the needle 8 to 10 millimeters from the incision line on one side, exiting on the other side of the incision at the same distance. Next needle is turned and entered 4 millimeters. So notice you're entering halfway. I'll show you in the picture in the videos. 4 millimeters from the incision line and exited 4 millimeters from the incision on the opposite side. Sutures are then tied. It's a tension suture. It's stronger than horizontal, less eversion, and again could disrupt microvascular. This is what you're doing. Now the drawing kind of is not the best, but I'll describe it and we'll show you in the video. So you take a bite as you normally would, go across, exit. Now you turn the needle around, and the horizontal mattress, you turn the needle around and went next to it. Here, you're actually gonna go in front of it, in front of where you exit. So take a big bite on this one so you can know what you're doing. So about halfway, you're gonna take a bite this direction, go opposite the wound bed, exit in front of where you originally entered, and then tie it. And so you can see there's the knot here on the side, and it'll be a vertically oriented knot as opposed to the horizontal. It'll make more sense with the video. I don't use this one that often myself, but so again, take a wide bite just for the purposes of practicing here, so you can have enough room. Come through, and again, ideally you would exit the wound and then re-enter it to go to the opposite side, or you can do what Doc is doing, which is going straight through. See how much struggle there is there too? I mean, obviously it's a prosthetic, but when you try to force that curved needle straight through, it can be a struggle. So come through, and now he's going to turn the needle around, and then he's going to re-enter about halfway in front of where you exited. And then you're going to exit in front of where you entered. About halfway point. See, he messed up, so he's repositioning. There it goes. And then tie it off. So you'll get the same dimpling effect. It'll be different orientation, but the same dimpling effect. You should feel the strength of this one. See, and then you're tying the knot now perpendicular to the incision, where before it was parallel. And that's the vertical mattress. How many folks have used this one before? Yeah, a little bit. Do you remember when you used it? Like what indication?
No, I was gonna ask you the difference between this one and
Yeah, so for me, the horizontal, again, I use it mostly for like stifle imbrication, so joint capsule. I'm trying to stabilize that patella, let's say, for like a MPL or LPL. Or those large wounds that just like dehisce, or like I know there's gonna be tension, like the ones that are like in a sternal position. This one, I don't really use it. I just don't really use it. It's because I want the benefit of bringing over more tissue, and so the horizontal mattress gets me there. This one, I think, I may have seen it used when you have like, the crotch of an incision. Let's say you have like a triangular, with an intersect, you can use it for this too. But again, I'm probably gonna use a cruciate pattern or something for that, so it just depends.
Yeah, I could just use it for the package too, but I couldn't remember why.
Yeah. I mean, probably a skin closure is my guess, because the skin can handle it. But yeah, for me, the horizontal mattress is what I'm typically going to. Yeah. Yeah. This is the cruciate you're doing, right? There you go. See that? Yeah. There you go. Feel the strength too. Yep. There you go. Push down. There you go. Yep. There you go.
I didn't get far enough apart, so I just
Yeah.
had to improvise my
No, it's good. It's good. You want to do this is the horizontal or the vertical one here? So wherever you exit. Oh, okay. You want to cut halfway. Yes. Yeah. So that's when the previous slides was like 8 millimeters. Yeah, whatever that is. Then the bite is 4 millimeters. It's halfway. Yeah. That's why I want a little bit wide. If you have too tight of a pinch, I can see that pulling through. That'll be the risk there with that one. Well, yeah, prosthetics have like the crotch there. Yeah, the V-shaped thing. Because that's where some of the incisions will fail at that junction. Replay the video. It's got to figure out orientation. Yeah, it's the orientation and the tension. That's why it's messing you up. There, see that? There it is. So you just got to figure out how to consistently get that. Exactly right. Yep. down even further. It'll get that part right even more. Lives are being saved in this room. Look at that. Prosthetics are going to do well. Yes, the knots do open up after you're done because these sutures are very, very smooth. You don't have the benefit of like sticky blood and plasma that helps put things together, yeah. And of course, it's not like real skin, so yeah, it's gonna loosen up. So as long as you know your technique is fine in real life, it's gonna be more secure. Okay, simple continuous. So another pattern. Starts with a square knot, one diagonal pass, and one perpendicular pass. If the needle advances above and below the skin, you get a running suture, which is not as good. Minimal tension holding good apposition, right? So that's head-to-head apposition. Good seal, pretty tight, but a problem if it breaks, because if the suture pattern breaks at any point, the whole thing's gonna unravel. That's the downfall of simple continuous, but it is way faster. So you're gonna start at one end. This is like we did way back in the beginning. Either square knots all the way, or surgeon's knot followed by square knots, whatever you want to do, and then you continuously take bites in the same pattern until the very end when you'll close your incision. So this will be Doc here doing it. And again, those of you who do a lot of surgery, this is going to be fairly rudimentary, but this is an awesome one if you're learning for the first time. Very useful. Again, if you're just starting out with surgery, I would avoid doing this in like small intestines. You want to do simple interrupted for those probably so you're more comfortable. But for linea alba, for example, this is a great one to learn. So surgeon's throw, or it can be a square knot, and then after the surgeon's throw or the square knot, subsequent square knots. So standard. This was our very first exercise here. Now he's gonna re-enter the skin on the same side that he started. So he's gonna start the simple continuous pattern. Probably doesn't really matter, but just for the purpose of consistency, start on the same side that you began with, and then come across. And you're not gonna cut anything, no knots. You're just gonna keep on doing this until you're ready to end the incision. And then we'll talk about the end, just for folks who are new at this. That end part of it is gonna be confusing in the beginning, but we'll show you how to do it. See, so it goes back to the same side that he started, come through. Also keep in mind too, he's staying outside of the loop. See that? So he's staying outside the loop. That's going to be important for the next pattern will be for interlocking. So you'll be in the loop for that one. For this one, when you hold the suture, see how he's rattling in his hands, take a bite, come to the other side. When you exit, you're staying outside this loop. Right there. He's staying outside the loop. See that? Outside. This is simple continuous. When I replay it, we'll go over how to end this, which he's going to do right now. That part will be a challenge, but I'm sure you once you try it, you'll be like, oh, okay, easy peasy. This is also where tension is going to matter. Again, it'll be loose here, but generally, as you're running your suture, as you're going down this simple continuous pattern, you're trying to maintain tension so that your previous bites don't start getting loose on you. Because if you can imagine, if you go through this, and then your second throw is like loose, then the whole thing is loose. That's it. You've got to start over again. So it's got to be perfect the entire way when you're working on a real patient. So maintain that tension on your suture line as you're going through it. Otherwise, you'll notice in these prosthetics, it's going to loosen up on you. Play it again. Beautiful. Maybe the end part. Yeah, we'll go with the end part. Also, that's how you feel like it, too. Oh, look at that, Yeah. Yeah. That part's very annoying. That's also why I tend to do cruciates too, they can get more tissue. But yeah. Yeah, either try to reshape it, try to reshape it to make more elliptical. That's probably the best way to do it. Otherwise, it's something in tension relieving, either horizontal mattress, vertical mattress, or cruciate. Yeah, that's the problem with that altogether. It's an area of high shear, and then the blood vessel problem. It's very annoying. Yeah, you could let that heal by second intention too, as long as you feel like the incision is healthy. Otherwise, then it's okay. But yeah, the crotch area is a challenge. This is the closure part. I'll play it back, just at the closure part, since that's maybe the most challenging. We'll play just the closure part so we can go through it. I probably need a slide just for that part, actually, I think, for future labs. Okay, so let's go back to that part. Okay. Okay, so you'll notice when you're trying to end it, you're going to have this loop. So you've exited now opposite where you started, right? You start on this side, exit opposite where you start. Now you've got this loop there. This is a continuous pattern. So he did a surgeon's throw. So right here on the free end, he's doing a surgeon's throw, which we now know how to do. Then he's going to grab that loop and pull it through. And so you're going to get that same double pretzel shape. It's going to look a little messier because now you have 3 strands total, 2 from the loop and 1 from the free end. But so you pull that across like that, and that becomes the equivalent of your surgeon's throw that you started off with, but now you've got 2 strands on this side with the looped area and not just the one that you started out with. See that? And so you'll have now on this side, again, here's your surgeon's throw. That's what he did right there. You have the loop still. Now you can continue on with the closure by doing square knots. So we try to ignore the fact that you have a loop there. You're just trying to pull it to the other side. See, you create that single pretzel shape now. Again, there's 2 strands here because that's what we're doing. But you get that single pretzel shape, which is a square knot. That's what you're looking for. And then you repeat that process. Grabbing the free end first. Working within the free end first, grabbing the loop part to pull it through. I'll play it again. There's a couple other important points with this closure too that we have to talk about is tension. So you're going to notice that maybe you're feeling like it looks weird or it's starting to loosen up on you. It's because the tension has to be equal. So we'll talk about that too. He does show it in a later video, but we should go over it now. So when you're about to end it, again, you create that loop, do a surgeon's throw, grab the loop, and then come through. Oops. That was me. Hold on. So now in this part, when you come through, this is where tension is going to matter. So when you pull this all the way through as tight as you can, you're going to be using equal tension on the loop side and the free end side. However, that's usually not enough. So on this side, once you tighten it, on this side, you can also put tension on each strand of the loop while you're maintaining tension on the free end. And by doing that, by pulling on one strand of the loop while holding this side, and then doing the other side of the loop while holding this side, you equalize the tension for your final closure. So on this part, see how he's about to go with his next move? Instead, what you do is grab one part, let's say this portion here with your needle holders, grab this part here, let's say with your hands, pull them opposite each other to get even more tension, and then do the same thing on the other strand. So hold this strand with the needle holders, hold this part of the free end with your hand, pull those, and then you'll feel it get a little more tight. So I'll play it again. And see how you guys are doing with the closure part. Nice and slow so you can see. Tighten down. Now we can move on to the next part. You can also pull on the strand while you're pulling on this side. Yeah, or the loop. Yeah. All in one side. This one strand like that, and then pull the other strand like that. And it tightens down more, so that got tighter. But while you do that, you're also putting tension on this side. There you go. There you go. That's it. Yep. Oh, other side. It's clear. There you go. Good. Okay. Oh yeah, good point. So then when you're done with this, you're gonna cut it. You're gonna cut that. Yeah. Yep. You have a loop at the end. You gotta cut that. So you're gonna have 3 tags at the end, not like a loop and a tag. You're gonna have 3 tags. Grab the needle, pull it out. Internal strand. Nice.
So it's really easy. And you only do it 2 times.
Nice job, guys. Anybody want more time with this one? Crushing it. Forward interlocking. So this is a modification of simple continuous. Each passage through the tissue is partly locked, linked to the previous passage through a created loop of material. At the end, the needle is reversed, the knot is tied to the loop left in the suture material. This has good apposition, good stability. So this one, if one part breaks, usually the rest will still remain intact, unlike simple continuous, where the whole thing will fail. But this requires more suture, and it is hard to remove. So keep that in mind with your staff who remove sutures at the recheck. That this will take longer to remove. It's fairly annoying to remove from the patient. So remember how we were stressing with simple continuous that you stay outside the circle, outside the loop? This one you're going to stay in the loop, and then you get this locking mechanism. So I'll show it to you now. This is a popular one with large animal folks, but I do know some small animal folks who do use the for interlocking. It'll start off the same way like any other pattern that we've been doing. You take a bite from one side to the other, surgeon's throw, or a square knot, depending on what you want to do. And then you continue on as a simple continuous, except that now you're going to stay in the loop, not out of the loop. This is a standard. Okay. So just like simple continuous, taking a bite on the same side you started, parallel to it, exiting, but now you stay in the loop. Yep, see that loop that he's got there? See the loop, he's staying inside the loop. Simple continuous, we would have been outside. We'll show it again now. Take a bite, you got the same side that you started, parallel to where you just were, come out, equidistant, and then staying in the loop. So there's that loop here, so the loop is created, he's staying in the loop, So just like simple continuous, that's the only change of this one, is you're staying in the loop instead of staying out of the loop. And then as you put tension on this closure, you will feel how strong this is. When it really locks in, it's very nice. Oh, yeah, of course. And then we'll talk about how to end this one once you guys are ready for it. That's why some people hate those needle holders with the scissors attached to them because they'll accidentally cut it. You know, I love the needle holders with scissors on, but some people just can't stand them. I'll stop the video here, and then we'll kind of go over how to end it once. Nice. Perfect. Yeah. Yeah, yeah, so put the tension on now. Yeah, so what happened is you get a lot more locking up here, and that's up here. It's gonna kind of depend on what it feels like when going through. It's of course way easier just to maintain tension the entire time. Yeah, because these sutures are all very annoying to remove. So where some continues, it's kind of easy to screw up. You can just, but yeah, because you notice here when you pull it, yeah, you get more tension on this side, yeah, and then other parts are loose. It's also the reason why though this is pretty secure, because if it does sever at some point, it still has a good chance of maintaining itself. But yeah, you may have to restart depending on what it feels like. No, still over the incision at the very end of it. You're going to turn the needle around. Yep, and go back, and that creates your loop on that side, and you can close it. Yeah, we're going to go over how to end this one here. Here it is. This is how he's going to do it. Actually, there you go. So you just finished it, and now you turn your needle around. This is opposite where you started, right? He started up here. So now he's entering. He's going to end this suture pattern. So he's going to enter on the opposite side, come across. That's what creates the loop. And now from here, it's the same as when we just closed it with simple continuous. Surgeon's throw, grab the loop, pull it through. Make sure the tension's equal, so you can pull on each strand of the loop while you're pulling on the free strand. See, he does that here now. See that? That's what he's doing. He's putting tension on both sides, and then square knot, square knot, square knot, square knot. I'll replay it. We'll play the closure part again. Here is the closure part. So again, he's ending it opposite where he started. He started on this side. He's going to end it over here. Turn the needle around. Go through. And that creates your loop on this side. So now you've got a loop here and a free end here. Surgeon's throw on the free end. Grabs the loop. Pulls him across. And then he's going to do that tensioning thing I spoke about earlier, where while he's putting tension on the free side, he's going to put tension on both strands of the loop to make sure it locks down even further. And then square knot, square knot, square knot. I'll replay it and come around and see how you guys are doing. And don't forget to cut the loop at the end, and that way you have 3 tags. Boy, I do not know how to forward this thing. So this is the closure part again. Oh, yeah, it's annoying. I don't have, yeah. You're closing it now, right? Yeah. Very good, very good. Nice. 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 The only thing I want to do for the future, remember to your bodies, try to keep them at the same level. You end up being like 2 sides are really close, it ends up like forming again. But that always happens like that, but that's for sure. Anybody need help? How we doing with this one? you are feeling the strength of the locking mechanism of this one. It's very strong. Yeah. We'll move on to the next. Yeah, what size did you like? 3? Yeah. Okay, so I think this will be the last one before our break. And then in the latter half of this will be fairly quick, but inverting pattern. So this one I put in here because people were requesting it, so I just did it. It might be a bit out of the scope of what you guys are aiming to do, but we'll see. This is an inverting pattern, like I spoke about earlier, where it sucks in the 2 edges, and we use it primarily for abdominal surgery, so most often stomach, uterus, and urinary bladder. There's 2 different types of inverting pattern. There's the Cushing and the Connell. The Cushing, when you go through it, the needle is going partial thickness in the tissue, whereas with the Connell, you see the needle going full thickness. That's the difference. Most of the time, I'm aiming for partial thickness because the suture material being in the lumen of that organ could be a problem, like urinary bladders, for example, because then all the solutes it creates itis, starts to accumulate around the suture material and can predispose them to cystitis and stones and things like that. Or if you're entering an acidic environment like the stomach, you don't want the suture to be dissolved by the acidity. But at the end of the day, at some point, this comes down to feel and personal preference. But that's the Cushing and the Connell. What you care about is the basics of this pattern. If you notice, unlike simple continuous, where you are going across, this is going parallel. So you'd be taking a bite, moving parallel, go across, parallel. That's the commonality between these 2 inverting patterns. So if you're doing this, let's say you're working on the stomach, you're doing a gastrotomy, your first layer of the 2-layer closure for a stomach, the first one will be a simple continuous pattern, which we all know how to do now. That'll be your first layer, and then you follow it up with the inverting pattern. So this is what you're ending up with. The inverting pattern, as you can see, sucks in the tissue. See that? How it does that? And you'll notice that to some degree on your prosthetic when you do this, but you can see the beginning suture, which is your standard surgeon's throw or whatever you're trying to do, and then you cut across, go over, another bite, go over, another bite, go over, another bite, go over. So you're taking bites parallel to the incision until you end up with an inverting pattern like that. I don't have a video or a schematic, so I'll leave the drawing up for this. If you guys want to take a stab at it, just start with a surgeon's throw and square it out as you normally would, and then take your bites parallel to the incision instead of across. Simple continuous, you went across. For this one, you go parallel to. And feel free to try it out. Not mandatory to know. This is kind of like a bonus sort of fun thing to try, so you can see how the tissue maneuvers with this. But you should see the inversion even with the prosthetics. And again, if you're not feeling this one, you don't have to do it. It's not essential. It's a fun one to do. Doesn't matter. Whatever you want. For our purposes, it doesn't matter. You can do it on the curved one. Yeah. You can do it on this one. That's up to you. It doesn't matter. you also want to try to do when you do this one is when you take the next bite, so let's say you exit here and you go across, you want to go across and enter at the same plane as this one. So you're going right across from it. If you end up going a little bit forward, a little bit back, it's going to mess up the pattern. Not the end of the world, but ideally you want to take a bite. When you take a bite, you want to be directly across, and then go parallel, go across, go parallel, go across. You're creating like a zipper type of a pattern. But you'll notice that as you play around with it more. If you mess up, you'll see it kind of like be a bit wanky on the alignment. And again, not the end of the world, but if you're trying to go for perfection, you want it to be head on. And then to end this one, you can end it like this, simple continuous. Just take a bite straight across, and then use that loop to close it. There's not much to it. But make sure that you put tension on either side because of that loop when you close it, because you're probably working on stomach or something like that. You want that seal, so you want to make sure that tension is there along the entire incision, and then when you get to the closure, pull on both strands of the loop while you're pulling on the free end, and that'll help tighten up the incision. Random incision. That's all. Yeah. And then at some point decide to. Yeah, so are you trying to end it now? Continue on? Yeah, so let's pretend. Yeah, this one's open this way, so yeah, you're going to take a bite here and go parallel. Yep. Yep. You can go parallel over. Yeah, there you go. There you go. That's right. That's right. Good. Yeah, so you want to end it now. You can either use this loop to end it with, or you can take another bite across. So use this incision here, taking that bite across, and then use this loop to end it. Yeah, either way. Servings, yep. Like that. Tighten both sides of the strand before. It's going to be a problem here because you have this incision. Yeah, this incision's fighting you and all that, but that's it. That's it. You can see kind of sucking those things. Yeah. How you guys doing on this one? Yeah, what size do you want? You just throw it? Oh, yeah. Yeah. The suture scissors.
Yes.
Suture scissors, yeah. Yeah, newer colors. Yeah, so that's where we're at. So, so this will be just a quick recap of what you've learned so far. The square knot, the surgeon's knot, simple interrupted, simple continuous, forward interlocking, cruciate, horizontal mattress, vertical mattress, and yeah, all thanks to PRN for sponsoring it. Give yourselves a round of applause. You guys did a whole bunch of stuff in a small amount of time. Going from not even doing this before, some of you, to now knowing all these things. Those are the basics for all this. So thanks, Dr. Miller, again. This is my information. We can take maybe a 10-minute break. When we get back, we're gonna work through just kind of bonus stuff, not mandatory, but we'll talk about the modified Millers, the Miller's knot, both for vascular surgery, as as well as some surgical techniques, tacking and walking sutures as well, that are kind of fun ones to know. But yeah, that's my contact information. Feel free to reach out with anything regarding telehealth or any questions you have. But we can take a 10-minute break. It's for, what time does this end? 4:30? Oh, okay. You guys want a break? You want to continue through? Let's keep going. All right, do it. Okay, so welcome back from our break. So burying the knot. So this is a way of trying to maintain the cosmetics of a closure. You're trying to bury the knot so that it's not poking outside the skin. It's mostly cosmetic. There is some function to it as well, especially if you're dealing with like really thin tissue. But burying the knot is a cool way of making the incision look better. So instead, when before we were working up here with starting our first knots, right, surgeons and squares knot, now instead you would start what we call deep. So you start deep where number 1 is, and then you exit superficial, which is number 2, then go superficial to deep, and then you tie the knot, and when you tie it up here, it's going to sink down and end up like this. That's burying the knot. Now it's going to be a bit tough on the prosthetics. There's not a lot of depth to these. I think that the ones you take home with you are going to be way better for this, for practicing this, but see what you can do, or otherwise at least you know about burying the knot. And the reason why you want to bury the knot is because then the next pattern you do is a subcuticular pattern. So let's pretend you buried the knot. Now, just like when we did simple continuous before or forward interlocking, instead now what you'll do is you'll enter the subcuticular tissue. So this is the skin here, this is the wound here, and this is subcuticular, the subcutaneous tissue. And you're taking the needle and going parallel to the wound, and you're creating that same zip fashion, right? Zipper fashion, like we did with inverting, but you're doing it in the subcuticular tissue. So that when you close this wound, you can't see the suture. It's all underneath. Now this part you can probably do okay on the prosthetics. Burying the knot might be a bit tough to bury it because there's no depth to these prosthetics for the incision, but you can probably try this subcuticular pattern and see what it looks like. And you should see your suture material basically be hidden if it's done right, or at least close to hidden, because again these aren't real animals, so it's not entirely amendable to this. But this is the subcuticular closure, which we use a lot. This is what I do. Most of my closures are this one. So a bit more advanced than what you've done so far, but it's cosmetically a nice one to have under your belt. I don't think I have any. Yeah, that's all I have on this one. So let me know if you want me to switch slides to bearing the knot or subcuticular. And then for the superficial layer, that might be enough. Subcuticular closure might be enough, and you're good to go. Sometimes I have to put a little skin glue here and there. It doesn't come out perfect. Otherwise, if you do this and you still kind of hate the way it looks, but it's closed up nicely, but it's still too much of a gap, then you can go back to cruciate or simple disrupted or simple continuous for interlocking, all the things you've already learned to kind of reinforce it. But if you can get really good at this, you might be able to get away with doing an additional layer and a little bit of skin glue to kind of seal the deal. No pun intended. Yeah, that's a tough up. These are going through the skin. These aren't really made for this. Yeah, all these other slides are like from people asking, so I just put them in here. Yes.
So I understand this concept you have procedures like this one now to right here
Yes.
beside it, so I don't have to go
You exit. So where you exited here, that's where you're gonna enter on that opposite side. Yep. There you go. And then you stay in this particular tissue and then come out. Yep.
And once you get to this
As you
part,
pull it, you see it. Yeah, see it's it's starting to go inside. You are supposed to. As opposed to where this one. Oh yeah, so it kind of depends on what part of the body you're working on, or rather how tissues are. Because sometimes I have to go back, but ideally you go across from it. But sometimes when you do that, it's just a wrinkle of the tissues. You're like, okay, I can't do it that way, and so I'll end up going back. Yeah, it kind of depends, but it's intended to be you look at the picture, it's intended to be like where you exit is also where you then enter on the opposite side. But in reality, it doesn't always work that way because sometimes, yeah, different breeds of dogs have different thickness of the tissue. So yeah. So I tend to like modify it as I go. Like it may be different the entire way.
It's
Yeah.
not a completely wrong way to do it, if it does its job.
As long as it's working, then it's fine. Because no one's going to see the sutures if this is done right. It's all internal. As long as you have a good CO, that's what you're looking for. Yeah.
At the time. So I did the 1, 2, 3, 4, 5.
Yes. Okay.
So, this one went in a little tiny bit. That part was supposed to
Yes. This part is, yeah, I think that's what happened. There you
And then
go.
do I pull that on the last?
Now you pull, yeah, there
Okay,
you go.
that's
And
a
then,
suture.
yep.
Okay.
And when you close that, you're gonna tie it, but by going parallel to the incision. Yep. You should still get that same pretzel shape you do. Yeah. It's only because, yeah, it's superficial, but that's the idea.
All right. That's so close.
But that also what can happen in real life too, so it's good to have it,
Yep.
yeah, this spacing. Oh. Yes. Or you can also just do like a regular knot we've been doing also if you want, you know, like a.
I don't think, I didn't go into the square. Did you want to go?
You see how, yeah, see that? That's beautiful. See how it's closing, you don't even see this the material. So that's excellent. Yeah, you basically bury the knot again. So to end this one, you bury the knot again. Yeah, that's the idea. Yep. So you have to position yourself in a way where you can just like vary it, go superficial or deep superficial, deep. That's what you're trying to do just at the end of it when you're ready to close it. Ideally.
I know, I'm like building it now.
So if you're gonna try and bury it, if you want to go, so superficial D, you can go across. Yep. Yes, it's tough with these. Just theoretically, when you go there, you actually penetrate right here in some particular tissue. Again, it's hard to do with these because they're prosthetics, but that's what you would want to be in that between area. So it's not trying to be like this layer. So when you do this instead. Again, it's more opposite of that. Yeah, it's a minor detail, but that's how you can get that bearing if you're trying to go for it. Yep. And then do superficial on the other side. Yep. You're trying to exit at that junction, so. All the way through. But again, this part would have been yeah, it'd be in here. It's just there's no room for the prosthetic. But that's the idea. Oh yes. Well, yeah, you would have buried it. If you're doing it this way. Yep. Uh-oh. Do you need another suture? Yeah, that's why it's not ideal. The ones that you're taking home with you are much better for this type of practice. So if you decide you want to practice this on the prosthetics, take it home, it'll be way easier to do this. These prosthetics are not. Okay, let's go here. You guys are good. We'll start with tacking suture. So, tacking the subcutaneous tissue layer to the deeper fascial plane, useful for decreasing or eliminating dead space. And by the way, dead space is when you have separation of layers. And so what the body's going to do with that separation of layers is going to try and fill it up. And usually it fills it up either like plasma or serum, so you get a seroma, or blood, or you get a hematoma. And that, of course, is bad for wound healing and it promotes infection. So you want to eliminate dead space. So the tacking suture, this is me drawing this, that's why it looks bad. The tacking suture is you're taking a bite through the skin, going across the wound, coming out, this is what you've been doing the entire time, turn back around, go through the skin, and now you tack it here. So you actually put the needle through the wound bed before exiting out the other side. I'll show you on the video here. So watch what we're doing. So he's going deep to superficial, superficial, deep on the opposite side. And again, this will be hard to do in the prosthetics, I realize that, but I just want to give you exposure to this. So when you do practice at home, you'll have it. And then takes a bite of the actual wound bed before reuniting with the free end on the other side. And what that does is it's going to pull that tissue closer together. See how it pinches it closer together? So these are used for like really big wounds where you're having a tough time making them reach, or you just want added security. Every few stitches can be a tacking suture. That's the idea here. It'll be difficult on the prosthetics. You can do it. It'll require some manipulation. You may have to, instead of going across like this, you probably have to go subcuticular, like we did earlier, instead. But the point is just to practice, or at least be exposed to tacking suture. So you'd go like, let's say subcuticular, go across subcuticular, and then tack it, and then close your pattern. But that's tacking suture, just give you an idea. I would not tack every single part of your closure. I think that's going to create too much restriction on the animal and promote discomfort. But every so often, for a long incision, I'll do this just for added security. Radical mastectomies or a really big GDV or hemoabdomen, I'll tack it along the way just to make sure, but I'm not tacking every single one. I think it's going to limit the movement of the tissues, the natural movement. So feel free to try this one. Or again, your prosthetics at home will be a better one for this one. They're way more flexible. We'll do one more similar technique to this one after this, and then we'll talk about some vascular surgery.
Is it possible to do this one where you bring them out? You can't bring them out?
Yeah.
So then how would I start it? Because it seems so I don't have to be there.
So you're looking for this particular layer.
Yeah,
Yep.
right.
So then you just go
So like, do I start up here and then go?
Yeah, you start wherever it's reasonable,
Like,
right?
that's
Because
fine.
your incision's already closed up here, right?
Yeah.
So you're not gonna like reopen them.
Okay.
Yeah, so you just start like this.
here and then
Yes.
just go like
Yes.
this, like the same.
Yep.
Okay.
Yeah, it's close to where your knot is.
Okay, thank you.
Yeah.
Do you ever put in 1 and 3?
Some people do.
Okay.
Yeah.
So that's more comfortable.
Yeah. Whatever's more comfortable for you. What you don't want to do is like you're doing like hours of surgery and you're feeling the pain in your whether your hand or your knuckles or whatever. That's what you don't
My
want.
thumb keeps falling.
You
I
will
think I
feel
would
it.
put in there too far. Do you keep yours on the end?
There you go. Yeah. 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 And then this more like a pencil. There you go. That's it.
And then I would go right across from
Yep.
where it came out.
Yep. Again, you can modify that depending on how it's going. You can always backtrack a little bit too. Yeah, it might rip through. I never saw that. All right, let's go to walking sutures. Again, this is just another exposure. You won't be able to do this in the prosthetic. I don't think you will. But just to give you an idea. So I'll show you 2 slides. So walking sutures are intended similar to tacking sutures, but a bit more aggressive. You take a bite in the deeper layer underneath the dermis, and then you exit that, and you don't take a bite in the wound bed directly across. You actually move forward and take a bite. And when you tie these two together, you're going to see this layer be brought forward. This takes advantage of mechanical creep. Mechanical creep is when you're slowly stretching a tissue and it elongates. Skin is remarkable. It'll do that over minutes of stretching. So I literally will have like an intern or something like, pulling two tissues together, and the skin will start to elongate over time. It's good for like radical mastectomies again, or those big wounds or big masses that you're removing where you don't have enough tissue there. Here's a nicer picture of it. Again, your goal is to move this piece of skin, this incision, closer to midline, closer to this dotted line. So you take a bite deep here, take another bite in front of it, basically where you want the skin to end up, and then when you tie these two ends, you get the skin to move forward, like in this picture here. So there's your knot, and you've now brought the skin closer. This is usually large size suture that I'm doing this with, large animals, or larger breed dogs, for example, and I have some tension. Typically the center of the elliptical incision is where I'm going to be applying these, but it's a nice, helpful technique. It might require some undermining. You might have to dissect the tissue underneath here, which in itself is a cool technique because you don't want to ruin the blood supply either. But the goal here is to bring that skin closer to midline. That way the rest of your closure has less unwanted tension. So that's walking sutures. You can try it on your prosthetics. I don't know if you'll be able to do it. They're not very good for that, but I want you to be exposed to it. Any questions just in general about walking sutures? Now this is one knot that a lot of folks who are more advanced want to learn. I don't use this one, but we'll go through it. I've got 2 videos on it, and it might be a fun one to challenge yourself with. It's the Aberdeen knot. And so I'm going to watch this video. You can do it in slow motion. This is the Aberdeen. So basically you've done a simple continuous pattern, like normal. So a surgeon's knot, then a bunch of squares, then a simple continuous, and then you're at the end. And instead of using your instruments and instead of tying your typical knot that you would with simple continuous, you're going to do the Aberdeen. So it's like a slip knot type situation where it's supposed to be faster. That's the idea here, faster and secure. So this is the Aberdeen. They make it look really easy, but it'll be fun to see you guys try it. And then kind of knot. So I'll play that again. The trick that I'm finding with this one is the amount of tension. How much tension you put on the loop end and the free end is what determines success. Because you'll if your tension is wrong, you'll easily just pull it through and like nothing ever happened. Whereas the goal obviously is to get a tight knot at the end of this. So this is the Aberdeen. If you're going to try this one, I'll try to help you. I don't do this that much. Has anyone ever done this before actually in practice? You have? Yeah. Okay. Yeah. So feel free if I get stuck, maybe save my ass. Play it again, and I'll play another video showing the same knot. Sometimes one video resonates with you better than another, but yeah, this is Aberdeen. Yes, do you care about the signs? Okay. So simple continuous pattern, like you've been doing, and then the Aberdeen to finish it off. Other video might be hard to see. Let's see what you think. But this person did what I think is a subcuticular pattern, and then they're ending it with an Aberdeen. So you see, so they still have the same loop, even though it is a subcuticular instead of continuous. Same loop and Aberdeen knot, tightening it down. And then what they're going to do at the end, they're going to smurf it. So, because this knot that you create is very bulky. And so if you want it to be underneath, you want it to be buried, which is what they want here because they did a subcuticular tissue that we've learned about for burying, you can smurf it. So at the end, the surgeon's going to come through, push the knot down, so they have a knot there, and they're like, oh, this knot is bulky and it's sticking out, let me get rid of it. They're going to take a bite in the wound bed and then exit somewhere else externally through the skin. Take a bite and then come out and then pull through and then it sucks in the knot. And that way you get a prettier closure. You don't have a big knot that's hanging out. I'll play it again. So So either simple continuous or subcuticular, ending it with Aberdeen. And the benefits of this is that it's fast, secure, and you do it, it's a hand tie.
Are you doing like 4 throws on the end of that?
It looks like it, yeah, yeah. On both videos, I think he did 4 throws. If everybody has another opinion on that, feel free to use it. If you use not.
And then he's just cutting the loop
Mm-hmm.
and smurfing the.
Yep, the remainder. Yep, plating it. Yep. Oh, you got rid of the loop through pulling it through. Maybe play that part. Play it? How do I? There we go. Here, so. So this part, so you took it through it, and then pulled it down, and that's what got rid of that loop. And then you smurf that. I can play it again. probably too close to the first knot. Well, if you want the, we'll have a video anyway, you can always try it at home too. But we'll not give you this, it's a tough one. I tried finding more videos on this one online, and only found the other one, the second one. And then I just want to touch on here as a closing with vascular surgery. This is, of course, again, if you're planning on spaying or splenectomies or whatever. I don't have any instruments for this, so people have been using either like a pen or like a rolled up piece of paper to pretend like that's a blood vessel. But essentially, we're going to go through modified Millers and Millers, and so these are not skin closures; these are purely to ligate vessels. So the idea here is to give you alternate means of ligating the vessel outside of transfixation or circumferential. So this is the modified Millers, which is easier. It's not as secure as the Millers, but it's a bit easier. And so if you take a loop of paper or a pen and you place a suture around this pattern, that's a nice way of occluding a blood vessel in preparation for a spay or a splenectomy. So I'll play it again. So if you want to play around that, you can. Obviously it's not essential, kind of goes beyond what we've been trying to do today. But I'll play this one and then I'll play the Millers and we'll close. Yeah, so two loops around the blood vessel and then looping it around both of those loops you created, then tie it in a knot. That's the modified Millers. One more time, folks want to try it. We won't go too much into depth with it. Just want to expose you to it. So one loop, and then parallel to that first loop, repeat, and then bring that suture in between both those loops you created, and then tie it. And that's a modified Millers. Easier, but less secure. Somebody in the class yesterday said that there's a paper that came out that compared the modified Millers to the Millers and found that this one is a high risk of undoing itself once the animal's awake from anesthesia, whereas the Millers was much more secure. So, does anybody here use the modified Millers or the Millers? Yeah. Modified. You prefer that over the other one? And same thing, yeah. Yeah, the modified, it looks so much easier, but I'll show you now the Millers. This picture's pointless, so we'll just go to the video. So this is the regular Millers not modified. So one loop around the blood vessel. And then now you're going to come across. So instead of parallel, you're going across that first loop to create that second loop. Now Now he's gonna do this part in slow motion. So, go in between them. Do that first loop you created, and that creates your knot. So a bit more convoluted, but apparently a bit more secure. So it's one that you can practice for those who are doing vascular surgery. Let's just play it out, and then we're done. I'll give you guys the prosthetics to take home with you. This line here. Or a book practicing this one? Yeah, go for it. Really good. Cool. Yep. Yeah, exactly. No, it's not crazy complex. Just what I would say is usually we're gonna practice a new vascular knot. I would probably place 2 knots in the patient, have the one you're more comfortable with, maybe more distal knot in the patient, yeah, and then that one will feel better. Yes. So normally for me, if it's like a spay, for example, it'll be I'm gonna do transfixation, which will stay in the patient, and then the circumferential just to kind of back it up. But for like a splenectomy, it'll probably all circumferentials, or honestly, ligature or something, quicker. Yeah. Yeah, I have to bring the paper because she just told me that, so I just took her for a word on it. I have a little paper actually see, And then of course it's like, how many animals they have, and there's another that supports it or not, and all these factors, So you never know. These things have people have used these for a while, and it's worked pretty well. Oh yeah, I do have a sharp container here. If folks don't mind passing it around, putting sharps in here. I'll start over here. Thank you. We used to have these labs at like circular tables, but now we're doing these regular tables. So yeah. Anybody want to see any more of this? Happy to play it again. So I'll end again by thanking PRN for sponsoring this. Thanks Dr. Miller for supplying me the slides. Again, my contact information for everybody who needs anything, and great job. Learned a ton of stuff today. Well done. Yeah. And feel free to keep those little pads home. Everything else I have to take back, but that's it. Thanks guys. Yeah.
You're taking the instrument?